Good morning, everyone. At the outset, I would like to congratulate Dr. Atul sir and the entire organizing committee of MAPICON for this conference. So the topic for me today is metabolic dysfunction associated steatotic liver disease. In short, MASLD, a term which has recently replaced the old term that was NAFLD. To begin with, first, what's in the name? Why this change of name was needed? If you look at the old term NAFLD, when it was first coined way back in 1980 by Ludwig, it was mainly used in patients who were obese and on biopsy they had steatohepatitis. So it is basically a diagnosis of exclusion, not any criteria was defined. But over the years, as we have learned more about the pathogenesis and the etiology of this disease, it is now more clear that it is more commonly associated with a term which we all called as a metabolic syndrome. So NAFLD term per se was not doing justice to the true etiology of the disease. The other reason was the stigma. There was a certain amount of stigma, if you see, which is associated with the term fatty and alcohol. Many a times a patient visits to us in the OPD with an ultrasound report and saying, "Doc sahab, liver fatty ho gaya mera." So these two were the main reasons behind the change of term. Eventually in 2023, a multi-Delphi consensus was made, and what they did was they used an umbrella term which was a steatotic liver disease, and which encompassed the entire spectrum of steatotic liver disease, namely MASLD, which we will discuss today. Then MET-ILD. This was an interesting kit which encompassed metabolic dysfunction and alcoholic liver disease, because the studies have shown that in patients who have got MASLD, the consumption of alcohol potentiates the progression to MASH. And then there was alcoholic liver disease and other causes of steatotic liver diseases. Coming on to the criteria, once you diagnose a patient with a steatotic liver disease on the imaging or biopsy, then you have to see whether there is any risk factor for patient fits into any cardiometabolic risk factors or metabolic syndrome. And if patient is having 1 out of 5 metabolic syndrome criteria that were BMI more than 25 and 23 in Asian population, fasting serum glucose of more than 100, or patient is on any diabetic drugs, patient is having BP of more than or equal to 130/85, or patient is on an antihypertensive drug, or patient is dyslipidemic or is taking any lipid lowering agents. If yes, then you have to rule out any other cause of steatosis, and if patient is not having any other cause of steatosis, then you label the patient is having MASLD. The next problem was, once this coin was termed, the thing that came in mind was, over the past 40 years, there have been number of studies that were done on NAFLD. Can those studies be used in MASLD patients also? So for this, there was an analysis of Indian Consortium on MASLD, also known as ICOM-D, which was previously ICON-D. What they did was they studied 7,000 NAFLD patients, the clinical profile of NAFLD patients, and they found that almost there was an overlap of 98% in the clinical profile, the FIB4 criteria, the LSM, which was fibrosis, overlapping with MASLD patients. And the similar results were also found in other parts of the world, in which the percentage of the patients with NAFLD had the MASLD criteria almost 99%. Thus, concluding that the epidemiology, the clinical profile, the biomarkers which were previously used in NAFLD studies can be extrapolated to MASLD patients also. Prevalence: with the growing obesity epidemic in India, the prevalence is increasing. It is approaching approximately 30%. Pathogenesis: it is a complex interplay of the various fibrogenic cascade which is happening in the liver. There is increased accumulation of carbohydrates and fats, which leads to de novo lipogenesis, thereby increasing triglycerides. It leads to endoplasmic reticulum stress, lipotoxicity. Then there is insulin resistance, which leads to increased accumulation of free fatty acids, subsequently leading to increased triglycerides, ER stress, and lipotoxicity. Then there is activation of Kupffer cells, which leads to inflammation. Inflammatory cascade is activated, all potentiating to leading to MASLD and MASH. Coming on to the diagnosis, the first is the imaging modalities, abdominal ultrasound. It is with the first and foremost test which each and every one of us use because it is widely available, it is inexpensive. However, it is operator dependent and it is accurate only if more than 30% steatosis is present. With the advent of transient elastography, it was a game changer because it can not only diagnose steatosis, even milder steatosis also, it can also tell you about the fibrosis by providing liver stiffness measurement. Then there are other imaging modalities like CT and MRI. However, their use is restricted because of the cost and they are predominantly used in clinical research settings only. Then there are commonly used non-invasive tests. I will not dwell into much detail because of the shortage of time. It is altogether a different topic. However, just a short note that there are simple OPD based tests now available and you can easily calculate on your mobiles, and these are FIB4 index, NAFLD fibrosis score, APRI index or AST upon platelet ratio index, and if these are positive then you can subject the patient to the further testing. Liver biopsy, it is an imperfect gold standard because it is one of the most accurate tests which can tell you clearly about the degree of steatosis, steatohepatitis and fibrosis. Imperfect because it is invasive, it is painful, it has got its own degree of morbidity and mortality, and it is impractical for population screening. So its main use is limited to if you want to rule out any other diagnosis. This is a risk stratification flowchart which I think every one of us physicians, endocrinologists and gastroenterologists should use in our daily OPD. If you diagnose a patient with MASLD, then you should subject to one of the non-invasive tests which we have just discussed. If FIB4 is more than 1.3 or more than 2, then patient is probably having a high risk for MASLD or MASH, and then he should be subjected to second line non-invasive test like transient elastography. And if transient elastography values are more than 8, then yes, the patient is having significant fibrosis and he should be referred to a gastroenterologist and a hepatologist. And if patient is having FIB4 value of less than 1.3, then the patient should be subjected to a repeat non-invasive test in 1 to 3 years. Management, usually the first line of management is the lifestyle interventions. This is the cornerstone of the management for patients with MASLD. And then there is pharmacotherapy, and there are two types of pharmacotherapies. These are liver-directed therapies for MASLD, and there are therapies for managing diabetes and underlying cardiometabolic risk factors. Regarding lifestyle management, both ASLD and EASL have laid down clear guidelines for this. Regarding the weight loss, a reduction of more than equal to 5% of the total body weight leads to reduction in the liver fat in obese patients. A reduction of more than 7 to 10% leads to improvement in liver inflammation, and reduction of more than equal to 10% leads to improvement in fibrosis. In patients with lean NASH, a reduction of 3 to 5% of total body weight leads to reduction in liver fat. Regarding dietary interventions, there are clear-cut guidelines to follow the Mediterranean diet or a plant-based diet, which includes consumption of more of fruits, vegetables, lentils, olive oil, and more of unprocessed poultry food. Limitation should limit the consumption of ultra-processed and saturated fats. Regarding exercise, 75 minutes per week of vigorous exercise or 150 minutes per week of moderate exercise leads to reduction in liver fat, and then obviously you have to avoid alcohol and smoking. Coming on to the pharmacotherapy, the current pharmacotherapy aims at reducing hepatic steatosis, improves insulin resistance, there are anti-inflammatory agents, and there are anti-fibrotic agents. The pharmacotherapy we will discuss today, we are only limiting it to the drugs that are currently available in India and is being currently used for the patients in MASLD. The first drug which has been used for long is vitamin E in a dose of 800 international units per day. It is an antioxidant and it reduces the oxidative stress. It has been recommended in non-diabetic MASH patients with F2 and F3 fibrosis. However, it has got its own certain limitations, as it was found that it increases the risk of prostate cancer in men, and there was a higher cardiovascular risk and increased risk of hemorrhagic strokes. So use it with caution. Then there is resmetirom, which is a THR beta agonist. These THR beta agonists are the receptors which are predominantly expressed in the liver, and they reduce the de novo lipogenesis in the liver, and they increase the hepatic cholesterol clearance. A Maestro-NASH trial was performed for this resmetirom, and they showed that it reduces both inflammation without worsening of fibrosis, with minor GI side effects like diarrhea and nausea. Then is the GLP-1 agonist. They act by improving insulin hepatic sensitivity. They decreases inflammation, reduces hepatic lipid accumulation, and they were generally well tolerated with side effects like cholelithiasis, cholecystitis, and minor heart rate elevation. Semaglutide has been a game changer, and it is emerging as a leading pharmacological candidate for the patients who have got both MASLD and MASH, with ongoing trials demonstrating its potential to improve liver fat, inflammation, and hepatic fibrosis. So this was a systematic review and meta-analysis which was done for semaglutide. Dose was 0.4 mg per day, and they showed that the treatment with 24 weeks of semaglutide could significantly improve liver enzymes, reduce liver stiffness, and improve metabolic parameters in patients with NAFLD NASH. Then there are dual and triple incretin agonists. There is tirzepatide, survodutide, and retatrutide. Of this, only tirzepatide is available in India right now. Survodutide and retatrutide are not yet available. A short word on tirzepatide: it is a dual agonist acting on GLP-1 and GIP receptor agonist. In this phase 2 multi-center trial, using a dose of tirzepatide 5, 10 or 15 mg once weekly, comparing it with placebo for 52 weeks, they showed that tirzepatide significantly improved the MASH without any hepatic fibrosis worsening in 44% in 5 mg, 56% in 10 mg, and 62% in 15 mg of the patients. Then we have got PPAR, that are paroxysmal proliferated activated receptors in patients with MASH. There are basically three isoforms which are expressed in liver. These are PPAR gamma, which are the main target of actions of pioglitazones. Then there is PPAR alpha, which are the main targets for fibrates. And then there are PPAR beta and delta, on which elafibranor acts. Out of these, saroglitazar, pioglitazones are available in India, so which we will discuss. Pioglitazone, it has been extensively studied with combination with vitamin E in patients with biopsy-proven NASH, and it has shown that there was a significant improvement in liver histology, with MASH resolution achieving in 47% of treated patients compared to 21%. However, its use was limited because of its side effects. A 30 mg dose per day dose led to weight gain and worsening of heart failure. Studies are undergoing with the lower doses while mitigating its side effects. Saroglitazar, it is a novel dual PPAR alpha and gamma agonist, and recently it has got a DCGI approval for treatment of MASH. Well, it acts by decreasing hepatic steatosis and insulin resistance. It decreases hepatic inflammation by acting on the comfort cells, and it decreases hepatic fibrosis by preventing hepatic stellate cell activation, and reduces collagen deposition by reducing pro-fibroblastic factors. Well, this was a evidence 2 phase 3 trial of saroglitazar, which was performed by Dr. Sareen, and it shows that the saroglitazar in doses of 4 mg at week 52, it met the primary endpoint of resolution of NASH without worsening of fibrosis. There was improvement in liver parameters from baseline to week 52, and there was improvement in lipid parameters from baseline to week 52. Then there is SGLT2 inhibitors. The main study has been done on dapagliflozin. This was a DEAN trial which at 48 weeks showed a significant improvement in MASH without worsening fibrosis in 53% of the patients. Omega-3 fatty acids, it is an anti-inflammatory and lipid-lowering properties make them a promising option for MASLD and MASH management. A meta-analysis involving 9 studies reported a significant reduction in liver fat and AST levels. Well, in current future, there are multiple drugs which are in development for MASH in US, European Union and Japan, and few years we will have more drugs in our armamentarium which will have both anti-metabolic, anti-inflammatory and anti-fibrotic properties. This is a flowchart which can help us in managing the patients who have got MASLD. So if a patient has got a non-diabetic MASLD with no significant fibrosis, only lifestyle intervention is enough. But if the patient is having a significant fibrosis with an LSM of almost 15, then the patient should, along with lifestyle measures, can receive semaglutide, tirzepatide, resmetirom, saroglitazar or vitamin E. If the patient has got diabetic MASLD without significant fibrosis, then along with lifestyle measures, we can use semaglutide, tirzepatide, SGLT2 inhibitors and pioglitazons. If a patient has got a significant fibrosis, then along with lifestyle measures, you can use, along with the other drugs, pioglitazons and saroglitazar also. A word about bariatric surgery. In a meta-analysis by Lee et al., they have confirmed that after bariatric surgery, there was improvement in liver histology, including steatosis, ballooning degeneration, inflammation, and fibrosis. It can be considered in individuals with a BMI of more than equal to 27.5. However, a word of caution that even after bariatric surgery, there can be worsening of NAFLD. To conclude, MASLD should be considered in patients who are high-risk groups such as type 2 diabetes, who are pre-diabetic, who have got metabolic syndrome, and should be followed by an appropriate workup. A holistic personalized care involving all primary care physicians, endocrinologist, nutritionist, and gastroenterologist is needed. Thank you for your patient listening, please.